Now, developing guidelines is all very well, but it's only the first step. It's necessary but not sufficient, because we have an ignoble tradition of guidelines laboriously created which are never implemented. So the next stage of this is to focus relentlessly on implementation. As I mentioned, there will be a call by WHO for countries to take this and to adapt it, either for the whole country or for particular groups. It's suitable to be adapted, for example, to vulnerable groups. It's deliberately based upon good practice from the children's guidelines, and that includes the requirement to produce training guidelines, supervision guidelines, all sorts of supplementary logistical material, and also to be embedded in training curricula. In fact, already here in London, colleagues involved in training medical students have said to me, oh, this is quite good, this is very clear, maybe this is even better than what we've had before. Next slide. So in the final section, I want to say something about implementation science. Next slide. Now, one way of thinking about this, and if you see the chart going through phase 0 to phase 4, is to think about the so-called whole translational medicine continuum. And on the left you can see normally what's called basic science discovery, cellular, molecular, genetic, lab-based research, and on the right we can see clinical practice, so-called implementation, sometimes based upon scientific knowledge. And in between various phases, so-called first-in-man studies, phase 1, early clinical studies or trials, phase 2, later or large clinical trials in phase 3, and then putting knowledge, including putting guidelines, into practice at phase 4. And it's really phase 4, that gap before it, this T3 knowledge gap, which I want to focus upon for a moment now. Now you can see here, in terms of medical articles catalogued each year with the next slide, a huge explosion of knowledge. You can see here that the chart is showing that by the year 2010, 800,000 new biomedical journal articles every year. Impossible numbers to understand. So in terms of the basic foundation of science, we have an almost unimaginable richness of new data. Next slide. And yet in terms of knowledge about implementing evidence, including implementing guidelines, we have almost nothing. I've found in a recent search only 12 papers about implementing mental health guidelines, for example. So our knowledge is really quite thin at this stage about how to practice all the information we have from these systematic syntheses of the evidence. Next slide. Now, we already know from background materials such as this paper in the Lancet, in the 2007 Lancet series, a lot about the barriers to treatment. Next slide. We know that in many low-income settings it's a question of insufficient investment. We also know that it may be the concentration of those resources in large urban settings. But also we know in some other applications, such as relating to deprived populations in urban settings in rich countries, that some of these factors still persist. For example, the lack of investment. For example, the lack of provision of proper physical health care in relation to people's physical health needs. And also here we can see not just the low numbers of staff on the next slide, but also the lack of leadership. Classically, spending time focusing on the needs of the most deprived groups has not been the classical way to the top, either of academic medicine or of public service hierarchies. Next slide. Now we're beginning to see attempts to systematize what we know about grappling with and beginning to solve some of these problems. In this slide here you can see the title of a recent collaboration, including Peter McGeorge, one of your conference organisers, about bringing together knowledge from across the world about what works to make better mental health care provided, not in policy, but in practice. Next slide shows that we've now produced a series of papers across these continents, again a specific one on your own region, led by Peter, trying to understand what has happened in terms of developing mental health care, what has worked, what hasn't worked, and what lessons we can learn from that. Next slide shows also another resource that may be helpful for you, with a new movement for global mental health, bringing together providers, service users, family members, researchers, people from many disciplines to share information across countries, across continents, about providing better mental health care. Now, if you're interested in some of these particular areas, we're also offering in June and in September this year short courses, 2 or 3 day courses, as a part of our summer school on the following 11 topics: about developing services, economic evaluation, complex interventions, international mental health, measurement, ageing, policy, qualitative research, coercive interventions, stigma, and social determinants. So you're very welcome to get further information if you'd like to go into these issues in more detail. So, to summarise, I've wanted to do 3 things in this talk today. First, to say something about the context of the scale and the nature of neglect that we apply to people as a whole who have mental disorders. Then thinking specifically about the neglect that applies to people in deprived populations within people with mental illness communities. Then I've gone on to say something about the development and the potential for these new World Health Organization guidelines, which I think offer real promise of usable tools to get evidence into practice on the ground in low-income contexts. And thirdly, I said something about the challenge of not just making the guidelines, but doing them, where we don't really understand yet the conditions under which practitioners will want and choose to change their practice to be more guideline and more evidence concordant, but it's vital that we approach this question with determination. So the next slide shows some other resources that you might find useful if you're interested in these topics. The top left one, for example, a recent book that I've written with Professor Tansella about planning and implementing better quality community and hospital-based care. And finally, I leave a series of references and resources. So in closing, I'm sorry that I'm not able to join you physically. I hope you'll have found that at least some of my talk has been relevant and interesting and useful for you, and I very much look forward to getting feedback from you about your conference, and I wish you every success with your meeting. Thank you very much for your attention.